Hi, everyone. Jeanette Goriab here, Senior Health Education and Engagement Specialist of Brain Tumor Foundation of Canada. And I have Dr. Jay Easaw back with us from Alberta, who did the live webinar for us last week. We didn't get through all the questions. Jay, we had 52 questions come through that day. It was the first time we've ever had that many questions. We got through about half. So we promised everyone that we would do a follow-up Q&A. And so here we go. This is part 2 of your webinar. So thank you for joining us. Yes. So we've kind of grouped the questions by topic. And so I guess one of the first questions is around testing for glioblastoma. So can you talk a little bit more about testing for glioblastoma or offer some direction on how to go about being tested, if that's possible?
Well, there's no blood test that we can do that can identify it. However,
sorry,
there is
I was going to stop you for a second because I didn't think I was recording, but we are, so we're good.
Okay.
We're good.
There is for some families who have a genetic predisposition like Lynch syndrome, there can be some testing to look at a predisposition to develop it. So that would be the first answer to the question. The way we make the diagnosis, though, is with pathology, with tissue. So we do need a biopsy. And in 99% of patients, we can get a biopsy. That sample is reviewed by a pathologist who does a series of molecular tests and looks at the actual anatomical characteristics of the tumor and can make a diagnosis. There is a very, very small population of patients where the patient's tumor is in such a high-risk location that they can't make a diagnosis, they can't put a needle into it, in which case that we will treat them on the basis of what it looks like on the MRI scan, because a GBM has a classic appearance. And so those are the three things. There are some limited genetic tests, but there needs to be kind of an impressive family history. 99% of the time it's pathology. Sometimes we're forced to treat based on imaging if the tumor can't be accessed.
Okay, perfect. Thank you for that. Next question is, are the survival medians similar between a GBM and a grade 4?
It's a very interesting question. So it used to be that we categorized grade 4 tumors as GBMs, but there's been a new anatomic classification. You have glioblastoma, GBM, and the median survival is 15 months based on the original study from 2005, although the medians appear to be shifting towards a longer survival. But there are some patients that we identify as a grade 4 glioma, and that's because of other genetic characteristics. For example, they may be IDH mutated. That predicts a longer is prognostic for a longer survival. And so those patients can live longer, on the order of several months longer in some cases. So we're starting to delineate between classical GBM and what we call grade 4 tumors that have a longer survival, behave differently in terms of how the tumor's baseline characteristics.
Okay, great. Thank you. Do you have any data to indicate the rate of progression from a grade 3 astrocytoma to a glioblastoma?
So when we think about, it depends on the genetics of the astrocytoma. For example, is it MGMT promoter methylated? Is there an IDH mutation? Those two genetic factors predict and prognosticate, respectively, improved survival. And so it depends on what the characteristics of the original grade 3, or we use the term anaplastic astrocytoma, are to then predict when it will transform into a GBM. An astrocytoma, grade 3 astrocytoma, wants to become a glioblastoma. That's its goal in life. And so a patient, for example, that has MGMT promoter methylation, has IDH wild type mutation, will transform, but we're talking now potentially 12 years, 10 to 12 years before it can transform in a tumor that doesn't have either of those good genetic characteristics. We could be talking as little as 2 or 3 years before. So you see this wide spectrum based on the genetics.
Yeah, perfect. Thank you. Oh, just lost your video there. Oh, there you are. There you are. Perfect. And the last kind of glioblastoma specific question is, what stage of glioblastoma is too late for gamma knife treatment?
We don't actually use gamma knife treatment for
Right.
glioblastoma. And the reason is because a glioblastoma sends out these tentacles. And gamma knife is a very focused radiation. So it can get the kind of the bulk of the tumor, but all of those tentacles don't get included. And that's because the radiation is so powerful, you can't radiate such a large amount of brain with that highly focused radiation. So that's why we use something called external beam, where we can cover those tentacles.
So a gamma knife treatment is more so for a non-malignant tumor, correct? So it's more
Exactly.
solid and easier to treat
Exactly
that
right.
way. Okay,
That's right.
perfect. So let's move on to some immunotherapy questions. It says, with GBM, we do not do any treatment after the original treatment of radiation and chemotherapy. We just go into the observation period. Do you see this changing in the future with immunotherapy, meaning only treatments happen if there is a recurrence? Is this correct?
Yes. So two answers to that.
Okay.
So that's a very good question. So for example, I also treat gastrointestinal cancers, and in esophageal cancers, after they're done their chemotherapy and radiation and have surgery, we can give them immunotherapy in specific circumstances. So there is precedent for this in other tumor types, but not in glioblastoma or brain tumor in general. At this point, immunotherapy doesn't seem to be working. And we're not sure whether that's because the drug isn't actually getting into the tumor itself, or whether there's enough immune cells, specifically T cells, that are available to then attack the tumor. But at this point, the answer is immunotherapy just really isn't working very well right now.
Right. Okay. Thank you. And is there a positive immunotherapy response in the body dealing with the metastasis? Is there a response in the brain with immunotherapy for a non-primary cancer like a melanoma? That's the question.
Yeah, I actually don't know the answer to that.
Okay.
So I think I mean, it's an interesting question. I'll try and answer it. So melanoma is exquisitely sensitive to immunotherapy, and it's kind of where immunotherapy first sort of established itself as having benefit. And melanoma before immunotherapy had a survival similar to glioblastoma, and now we're talking about median survivals on the orders of decades because of immunotherapy. These tumors seem so sensitive that in some cases immunotherapy can be helpful. But the brain is considered in many cases a sanctuary site for these tumors. In other words, it's a safe place for these tumors to grow, and they can escape the immune system sort of attacking it.
Okay, thank you for that. Okay, let's move on to some treatment questions. This question is, my husband's quality of life never improved despite chemo and radiation. He survived 1 year, but never had relief from the extreme fatigue and hallucinations. Is there any progress in finding ways to improve quality of life?
It is, in the absence of a lot of new treatments, the standard of care goes back to the 2005 study. So, we're 18 years from that, and that remains our standard of care. There is no other tumor group that has had such a slow rate of development. And the reason is, as I had mentioned in my talk, that it's just so hard to get all these great drugs that we have for other cancers into the brain. The brain has the blood-brain barrier.
Yeah.
And so a lot of the focus has been moved to quality of life. And one of the challenges here is that as is in this example, sometimes quality of life never improves or doesn't improve very much. And the reason is because the damage was done. The tumor has already damaged key parts of the brain, and that they're not coming back. Or the combination of the chemotherapy, radiation, and surgery, in addition to the cancer, have damaged areas to the point where the person can be alive, but those areas are still damaged. And as a result, you can have any number of clinical problems. Hallucinations, poor memory, fatigue are very common.
Okay, thank you. I know you talked a little bit about Avastin during your presentation. This question is just, what are your thoughts on using Avastin, and should it be used, or what are the risks, kind of risks versus benefits, maybe?
Yeah, so first of all, it's not covered in Alberta, and it's not covered in most of the provinces in Canada. And the reason is because there is not a survival benefit in the studies that have been done. So it hasn't been shown to improve survival. Where it does seem to be useful are in large symptomatic tumors because it
Right.
seems to decrease the swelling and the symptoms caused by it. So in Alberta, for example, if we felt that a patient would be a good candidate for Avastin, the patient has to pay for it. The province
Mhm.
will not pay for it. And so, and we're talking about pretty expensive drugs. I had quoted a cost for bevacizumab, Avastin, the original, and it was about $8,000 a month. But I have found out subsequently that the cost of some of the biosimilars, or the generics, if you will, of bevacizumab are in some cases much cheaper, maybe a
Mhm.
third to 35% cheaper. So yeah, they have a role in very
Yeah.
specific circumstances, no survival benefit,
Right.
but can be still beneficial for quality of life.
Okay, thank you for that. Let's talk about clinical trials a little bit. What about clinical trial, or sorry, what about clinical trials delivers chemotherapy to pediatric brain tumors using MRI guided focused ultrasound? I think there might be a couple of words missing from this question.
You know what? I'm not familiar with any clinical trials doing that, but I
Right,
treat adults, and so truthfully, I
exactly.
can't speak to that.
Yeah, no problem. Should there be a crossover in GBM trials or force a SOC slash placebo arm? SOC
Standard
stands
of
for
care
standard of
is
care.
probably
Yeah,
what they mean by that.
yeah,
Placebo. Could you read that question again?
sure. Should there be a crossover in GBM trials or force a standard of care slash placebo arm?
So I'm not really sure what that question is getting at,
Okay.
but I can speak to, first of all, the idea of a crossover. So
Mhm.
most of the trials that we look at overall survival, and that is a black and white endpoint. The patient's either alive or dead at the end of the study.
Mhm.
And so most of our studies are done geared looking at overall survival, this black and white endpoint,
Yeah.
because we want to know if patients live longer. What a crossover trial does is that they go onto a clinical trial and they don't wait for the patient to pass away or not at the end of the trial.
Mhm.
They look for progression. So the patient's still alive, but the cancer has progressed.
Okay.
At that point, the patient can cross over and get the other arm of the trial. So for example, if you had a standard of care versus, we'll just say, an immunotherapy arm,
Mhm.
um, and the patient on the immunotherapy arm progressed soon,
Mhm.
they could cross over and still get the standard of care.
Mhm.
Or vice versa, if a patient was treated with the standard of care and they progressed, they could cross over when they progressed to receive the immunotherapy arm. Why do they do that? Because it's actually a compassionate way to run a trial, because everybody gets access to the drug. The problem is it's it's a confounder, because you never know if the survival that the patient gets is due to the standard of care or due to the immunotherapy, because they got both arms. But it does speak to something called progression-free survival, the time to their progression. And that's still an important endpoint. But
Okay.
it is difficult to interpret those trials and then bringing them and getting funding for those trials from governments, because it's not a clear endpoint. The government wants to know, if they're going to fund a drug, does it
Mhm.
improve survival or not? And a
Mhm.
crossover trial can cloud that picture.
Okay, perfect. Thank you so much. Somebody said that they read a JAMA Oncology, the DC Vax-L trial
Mhm.
result from Dr. Liao. It looks good, not amazing though, the person says. Do you know when this will be available from Health Canada?
Yeah, I
I'm
think
not familiar with that trial.
yeah, DC Vax is a vaccine trial,
Oh,
and
okay.
it's a dendritic vaccine trial. It is, I think, on the basis of the clinical trial results being presented to Health Canada. We're not
Mhm.
sure whether this will actually go or not. But interestingly, I do have a patient on the DC Vax who
Okay.
got it many, many years ago, and is still alive and doing well on it.
Great.
But it's not to say, like, that's an N of one. We don't,
Mhm.
the way to look at something is in the context of looking at many patients over a
Mhm.
longer period of time, and that's where the clinical trial data is. But my understanding is that it's being presented to Health Canada.
Okay, great. Thank you. And some questions about the blood-brain barrier. I know you covered this a little bit in your presentation. Is there research into using lipid nanoparticles to deliver drugs to bypass the blood-brain barrier?
Yes, there are. And what those are is that a lipid nanoparticle is essentially like a shell, and inside that shell is the drug. The blood-brain barrier, one of the ways to get around it is with lipid covered micelles, essentially. It's the clinical term for it. But they attach to the blood-brain barrier, and then they can release their drug inside. This is technically very difficult to do, to then enshroud a drug in a lipid nanoparticle. But there is a lot of active research into this because this is a potential way to get around the blood-brain barrier. Nothing is approved or is the standard of care, but that's how it works.
Okay, great. Thank you. Do you know anything about the results from the focused ultrasound trials at Sunnybrook for delivering chemo across the blood-brain barrier?
No.
Okay.
No, I don't. Sorry.
Okay. No, it's okay. The next question is, I am on the targeted treatment Tafinlar and Trenitinib. Do you have any further information about these treatments?
No.
Are those types of chemo?
Well, trametinib is more of an immunotherapy drug, actually.
Right.
And I'm not sure which trial they're on. There's a trial called the Agile trial that's being run in certain centers across the country, and patients are being randomized to various arms, and the arms are kind of being modified as they go. It's kind of a way to rapidly assess a drug and make a go, no-go decision. That a certain number of patients will get it, and if they see a signal, they'll keep going. And if they don't, they'll drop it, and then they'll try another drug for another set of patients. That may be on that trial. What was the first drug? The trametinib is an IO kind of based drug.
Tafinlar, Tafinlar.
I don't know what that is.
Okay.
But we're not running the Agile trial in Edmonton, so I'm not familiar with all the drugs on that clinical trial. But it may well be that. That makes sense.
Okay, perfect. And we're just kind of in the last part of our questions, some miscellaneous questions, so to speak.
Sure.
Do you know if there's any literature that say the use of recreational alcohol during treatment or after treatment? Anything that the literature
that's
says
a really
out there?
interesting question, because the temozolomide can affect liver function, and in some patients it can actually significantly damage the liver. It depends on the person. My own experience, having done this for a few years, is it seems like it's females in general that seem more susceptible. And so you have a drug that is stressing the liver and in some cases damaging the liver. And then if someone drank alcohol on top of that, for some people, that's kind of the tipping point. And then we can see liver dysfunction, and in extreme cases, liver failure. And when we see liver failure, we have to stop the treatment.
Sure.
But my own personal philosophy on this is that the liver is speaking to me when I look at those labs. And you can quickly tell if the liver is in danger or not. For most patients, my experience is that if they want to have a glass of wine, with dinner occasionally, no problem. The body can tolerate that. But if there's, especially if there's drinking to excess while on temozolomide, that's kind of a double hit to the liver, has been our observation here.
Sure. Okay, great answer. Thank you. Besides Lynch syndrome, are there any identifiable risk factors for GBM?
No, it's idiopathic, which is a clinical way of saying it's really just bad luck. Cancer cell comes up and isn't cleared. We have observed a couple of things. One of them is controversial. We've seen some contractors, for example, who are on their phone all the time. Like they'll be driving with one hand and their phone is on, and they're and then we've seen some of the most aggressive tumors we've ever seen, sort of right in the temporal lobe, right beside them. So I think that there are some people who are vulnerable or potentially vulnerable. A second interesting thing is we've seen some patients who've been, for example, in car accidents and have had head trauma, and there's like a visible scar on the brain where they contacted their head, and in some cases we can see a glioblastoma arise from that area. Interesting. So, but those are totally anecdotal. They're not they're not evidence-based. It's just sort of observations we've made over time.
Yeah.
It doesn't mean that for every person who gets clocked in the head that they're suddenly going to get a glioblastoma, but we have observed that in some.
Okay, interesting. Anything new regarding leptomeningeal disease?
So the cancer can get into the meninges and into sort of the coverings of the brain. Not common.
Okay.
Not common. We see that actually more, in my experience, with metastases to the brain. So like a colon cancer that metastasizes to the brain, or breast cancer that goes to the brain. But we don't see a lot of leptomeningeal disease, at least in my experience, with glioma.
Okay, thank you. Just a couple more questions for you, Dr. Easaw. Is access to brain postmortem for pathology a benefit to research? If so, how does somebody provide access to a loved one's brain, so to speak? Do
I
you have
am
any info
such
on
a
that?
strong proponent of this. So before I got recruited to Edmonton, I was in Calgary,
Mhm.
and the Calgary Pathology Service, as an example, actually has a whole process that's already been established for brain donation. And what the pathologists will do is then they will go through that brain in incredible detail, and the amount of learning that we got by the pathologists who then reporting back to us was amazing. So
Mhm.
I am a huge proponent of that. And if this is something that someone is interested in, the way to do it is to talk to the your oncologist,
Mhm.
and they can talk to the pathologist who can then tell them whether there's a process or not to
Okay,
acquire that. But I'm a strong advocate. I think
that's
it's
great.
amazing.
Yeah, for sure. Another question, we'll end on this question actually, Dr. Easaw. It's about coverage for Temidol, and that it's not fully covered in all provinces. And I'll just preface to say to our audience that something I learned over the years is that when we go as a Canadian, when we go into the hospital for any kind of treatment, it's covered, right? It's covered under the Canadian Medical Act, so to speak. But as soon as we take a medication out of the hospital, like a temozolomide in pill form, it's not automatically covered. And so there's a lot of differences and a lot of challenges across the country around coverage for Temidol and or temozolomide, as we call it here. Any comments about that around coverage? Anything
Yeah,
new that you've heard?
no, and you're right. So, for example, here in Alberta, it's completely covered, and
Mhm.
in many provinces, it's completely covered. But in some provinces, and I could be mistaken because things may have changed, but for example, in Ontario,
Mhm.
there's a real distinction made between intravenous medications, say given in a hospital, and oral
Yeah.
medications, oral chemotherapeutic agents, and there's a whole different process. So I don't know if things have changed very much, but I can tell you it is nothing but a headache for the patients and the oncologists. Here, to be honest, it's fairly straightforward. We write the prescription, whether it's an intravenous drug we're
Mhm.
giving for another type of cancer or an oral drug, it's all covered under one provincial formulary, and it's just dispensed.
Right.
So
And so when we send this recording, I will include a link for everybody because we have a map that kind of outlines which provinces covers it, which provinces don't. Our advocacy committee has done a lot of work over the years around getting better coverage for our patients and families. So we'll definitely include a link and that playback. That's it. There were a few other questions that we didn't get to, but they're more personal questions and looking for personal opinions. And so about somebody's care, and I know that's hard for you as a physician to answer if the person's not your patient. So for those people, we really encourage you to talk to your physician, talk to your healthcare professionals, get a second opinion if you feel like you need to. But yeah, this was great, Dr. Easaw. Thank you so much for taking time out of your busy schedule to do a second recording for us.
no problem. It's absolutely my pleasure.
Awesome. And that's great. I'll just finish the recording here and we'll log off. So thanks everybody for listening, and let us know if you have any other questions.